That's part of the ribosome. So we have certain agents, we have quite a few agents that act on the 50S. This one acts primarily on the 30S, so that distinguishes it from other antibiotics. So you need to pay attention to that, okay? And in addition to its action on 30S, oh, these are bacteriostatic agents. It says bacteriostatic except at high concentrations, but these have always been known as a classic group of bacteriostatic drugs. So it means you've got to have a good immune system if you're going to be using them. Your patient does. In addition to that, these agents have been used to reduce inflammation in things like periodontitis. And so they have some specific additional mechanisms of action that have to do with inflammation and periodontitis, which we'll talk about on a subsequent slide. Right?
Arrow dog.
All right. So can I make this bigger?
Yep. Here.
Just switch it
Didn't do
up.
it.
Anyway.
Your new mouth there, right?
All right. Never mind. It doesn't matter. I can see it. So if you look at the picture, you'll see that it shows a ribosome with a tRNA coming in, and it's going to bind to a thing called the A site. So as the protein is being synthesized, there's kind of a ratcheting from the A site to the, I think it's the P site, or S side, no, the other side. And so the tetracycline prevents binding onto the A site. So as the T ribosome comes in, it can't lock on, it can't add amino acids to the protein. So that's the classic mechanism of action of the tetracycline. Okay, any questions?
You can make it the full screen.
So the next slide has to do with the effect of tetracycline on bone remineralization. And so what it's all about is that the tetracyclines, I'm going to go to the next slide, tetracyclines can interfere with the action of osteoclasts. And it does so by several mechanisms, one of which is it kind of reduces the effect of different inflammatory mediators onto the osteoblast, which reduces a hormonal input to the osteoclast. So tumor necrosis factor alpha and some other things, interleukins, activate the osteoblast to send signals to shut down the osteoclast. So that's one mechanism. And then another mechanism is that the tetracycline can actually bind to a zinc that is in the matrix metalloproteins, which would normally cleave the collagen in the bone. And so that's the second mechanism. I believe there's a third mechanism. But anyway, the point is that we have these alternate mechanisms. And in addition to being a different site of action, the dose that we use to get this effect is much lower. We can use a very small dose relative to the dose we've used for treating a bacterial infection. So we need to recognize that that's different. How are you doing?
I'm about to make it big.
Put it on
Presentation.
big screen.
Here.
All right.
No, just press the arrow.
Okay, so like all antibiotics, bacteria have acquired resistance mechanisms to prevent the action of the antibiotics. And so on this next slide, whoops, went too far, it talks about some resistance mechanisms. So we have decreased or increased efflux, that's the bacteria pumping the tetracycline out of the bacteria faster than it can have an effect on the bacteria. Decreased influx, so it's preventing the bacteria, the antibiotic from getting into the bacterial cell, and decreased access to drugs to ribosomes due to ribosomal protection proteins. So there's been these little errors that accumulate in the bacteria that have made them less sensitive to antibiotics like tetracycline, and those then get shared. Unfortunately, they get transferred to other bacteria. So we can develop rapid tolerance to tetracycline. Okay. Not sure whether that's a drone or what it is. Oral but parenteral preparations are available, so usually it's given orally. Doxycycline is rapidly and almost completely absorbed from the GI tract after oral administration, and it is absorbed best under acidic conditions. Partially inactivated by the GI tract by chelation, and we'll talk about chelation as a way that tetracycline becomes insoluble and cannot be absorbed. So even though you're not taking it with something that causes chelation, you can still get some in the gastrointestinal tract. Cleared unchanged by renal and bile secretion. So the point here is, now we get gas out of here. Utilizing tetracycline. But remember I said a long time ago that the liver can secrete drugs just like the kidney can secrete drugs. And so there is a secretion of tetracyclines into the bile. And that's how it's eliminated. It's not actually metabolized, it's secreted. So this just shows that in the... So you guys know what the smell is? It's not the actual gas. It's the smell that's a very potent, what do they call them? Indole compound that stinks. So small amounts of gas you can tell. But it's not necessarily toxic. All right. So one of the things that can happen to tetracyclines is characteristic of group of drugs, although when we talk about fluoroquinolones, they also have this problem, is they can bind to metal ions and become insoluble. So we call this chelation. And when you form a chelate complex, it's different than a lot of chemical reactions. So it's like a specific kind of chemical reaction. It's called chelation. This is an example of what chelation is. And the effect it has is it prevents the antibiotic from being absorbed through the gastrointestinal tract. So if you, sometimes tetracyclines produce gastric irritation or nausea and vomiting. So you want to take it with like an antacid? No, you can't do that because it will tie it all up and prevent it from being absorbed. Okay, here's an example of a hidden tetracycline drug interaction where another drug, in this case a angiotensin converting enzyme inhibitor, an ACE inhibitor, is formulated with magnesium and in some cases iron in the tablet. So if you took your tetracycline along with this one, quinapril, although you haven't given it with any metal ions, the metal ions were in the formulation of the other drugs. So you have to be, you know, when we look at the house supplied in clinical pharmacology, a lot of stuff you never look at because who cares? So this is one of the reasons why you need to care. So tetracyclines, look for metal ions in the preparation. The recommendation is to space the two drugs by long time differences. So you take the tetracycline and then maybe 3 or 4 hours later take the quinapril so that they don't interact. Adverse effects. So bind to tissue undergoing calcification during formation of bone. And in fact, we can get deposits of tetracycline in the tissue that later turn brown and look bad. And the binding to the calcium in the teeth actually causes defects in the growth of teeth and bone. So we can damage teeth and bone because the tetracycline is taken while they are growing. We can get increased liver toxicity in women who are pregnant. And so remember we said that sometimes you know, a pregnant woman is not going to have normal flow to the liver. So tetracycline becomes more toxic in those situations. So we just don't use tetracyclines in pregnant women and children under 9. So children under 9, you don't give tetracyclines because it will get into their bones and their teeth. And then pregnant women, we don't give it. And sometimes we can get the staining in the bones of the infant who was in utero when the tetracycline was given.
So is it it's increased toxicity in pregnant women, independent of the fact that they have if they're carrying a baby. It's just it hurts the mom as well as the fact that it can cross the placental barrier.
Both.
No? Okay.
Another weird toxicity we get with tetracycline, sometimes they'll produce a photosensitization of the skin, and the skin becomes more sensitive to the rays of the sun, and you can get burned badly if you're out in the sun after taking tetracycline. So we caution people about not getting too much sun. So this is just some pictures of the different kinds of problems. You can see that in this particular case, the individual got the tetracycline early, before the teeth had really started growing, and continued to get it for a while until they stopped, and then the enamel below that is fine. So this is because of the tetracycline in blood being attached to the teeth. And then in the bottom one, we see that it was given late, and so the gray banding is hot, toward the gingiva, and that's because it's basically depositing in the teeth after it was given. And then over here, what is this one about? Well, that's don't go out in the sun. You get a really bad sunburn. Okay, some other effects: vestibular reactions, dizziness, nausea, vomiting, particularly with minocycline. There are a lot of drugs that produce nausea and vomiting, but in this case, we want to bring some attention. GI effects: we get anorexia. People get kind of an upset stomach. So nausea, vomiting, diarrhea. So NVD, nausea, vomiting, and diarrhea. Superinfections. So this is a broad spectrum antibiotic. It's going to wipe out the normal flora of the gut or the vagina or the mouth. And so we can have an overgrowth of non-susceptible organisms. Fungi, Candida is not a bacteria, so it's not being affected by the antibiotic. So it grows happily, and so we get oral thrush or Candida albicans infections, and they can be in all those different places I just mentioned. So we're going to talk about antifungals in a few weeks, and the reason you need to know that is you may need to treat some of these infections if you gave tetracycline. Contraindications: we talked about pregnancy in children under 9. Avoid tetracycline in patients with kidney disease, liver disease, or kidney and liver disease. I hate to say it that way, but that's the way it runs. Pharmacokinetics: we take tetracycline on an empty stomach. Why? Well, mainly chelation. It's going to bind up to things that we might eat. So so it says that doxycycline and minocycline can be taken with non-dairy foods at least 2 hours before, 1 hour before, 2 hours after meals, and 2 hours prior to bedtime. So you need to take it before bedtime. What's that all about? So the tetracycline in high concentrations in the gut can cause irritation of the esophagus and actually produce lesions in the esophagus. So these are pictures of patients that have lesions in their esophagus because they took tetracyclines and then maybe just laid down or were prone or whatever. So part of the directions to patients taking tetracyclines have to do with preventing them from getting this kind of esophagitis.
Does the fact that they're free bases affect also when you take them?
I don't think that I don't know that it's due to, like some drugs, like phenytoin, it would be the basic nature of the drug, but I don't think so. Okay, so here's a big long list of things you need to tell patients if you're going to prescribe tetracyclines to them. And so let's just kind of go through it. It's best to take the drug on an empty stomach, 1 hour before, 2 hours after meal. Then it says if stomach becomes upset, take with food. This is not with milk or custard or stuff like that has a lot of divalent or trivalent metal ions in it. Do not take with an acid. We talked about that, right? Metal ions. Or iron, like taking it with an iron supplement would be the same thing. It is recommended that you do not take doxycycline with milk. To reduce the risk of esophageal irritation, ulceration, take plenty of fluids. And then it says take a couple sips of water, then take the tablet, then take more water, and then sit upright for 2 hours.
Daryl said that they hit a gas line out there. That's what that sound was, and they're canceling the rest of it. They're evacuating. So
We're going to
somewhere
live,
they're
so we're going to try to finish this.
Yeah.
And if you have to go, go, but
Yeah.
we're
But
doing it.
that's
Then they won't have to use your phone.
I'll have it anyways.
Okay, one thing down here, concurrent use of doxycycline may render oral contraceptives less effective. So use a alternate form of birth control. Remember what we say, use an alternate form of birth control until the next menstrual cycle. It should be like a barrier form of birth control until the next menstrual cycle. Doesn't say all that here, but I'm telling you. So we talked about candidiasis. They got a warning there, and report onset of diarrhea to a physician. So the reason you report onset of diarrhea to a physician is because you may have some kind of super infection going on in your gut. Everybody understand the table? Okay, this one says drug interactions. What kind of drug interactions we get? We get effects on warfarin. Sulfonylureas are another. Sulfonylureas, there's a number of different drug classes. So some of them are antibiotics, some of them are anti-diabetic agents, just a number of other agents fit that category. Digoxin. Digoxin is glucuronidated, so you can change the amount of glucuronidation, deglucuronidation in the gut because of the bacteria you're killing in the gut. So there's a warning there. Lithium, there's some toxic effects in the kidney. Remember, liver and kidney. Furosemide, which is a diuretic, and methotrexate. So may reduce the effect of oral contraceptives. Barbiturates and phenytoin can reduce the action. So barbiturates and phenytoin do what to metabolism?
Increase drug metabolism.
They induce the drug metabolizing enzymes in the liver. So this suggests that the tetracyclines will have reduced effect in the presence of these agents. So we talk about phenobarbital, carbamazepine, and who they had phenytoin. But carbamazepine is another one that does that. Now this is kind of counter data for the problem with oral contraceptives. And so in this particular case, it's evidence-based study that showed that even though they kept up tetracycline for 5 to 10 days, they didn't see any change in the level of the oral contraceptive. So there is a controversy about whether or not the effects of oral contraceptives are changed by antibiotics. Some of those that are used for the treatment of tuberculosis clearly change the metabolism of the antibiotic. We're getting closer. Tigercycline has a broader spectrum than tetracycline even, and so I just put that in here. It's not something we would generally use in dentistry. It does accumulate, like remember we talked about azithromycin being delivered to the inflammatory sites by the leukocytes. This one is also delivered that way. So even though the blood levels have gone down to 0, you may still get delivery of the antibiotic into inflammatory zone. Contraceptives and warfarin drug interactions is a third choice drug. So normally you wouldn't be using it. But it is has a broader spectrum. It's not used for antibiotic-associated colitis. So one of the ways dentists use tetracyclines is for the treatment of periodontitis, and we use that matrix metalloprotein property to reduce bone reabsorption in periodontitis. And so we can actually deliver, I think it's doxycycline, but it's delivered in strips that are actually stuck into the gingiva for a local action around the teeth, which would prevent some of the systemic adverse effects. Let me get the rest bit. So one of the agents is Periostat. It's a 20 milligram strip that goes down into the teeth. So then there's some recommendations on how you'd write prescriptions for tetracycline. And so if you look at Dr. Edwards' stuff last year, I changed this because he wasn't really doing it right. So this is more accurate. And so basically, says doxycycline 100 milligram capsules, dispense 11 capsules, 2 capsules by mouth, 2 hours prior to bed on day 1, then take 1 capsule 2 hours prior to bed every day for days 2 through 10. And then it should say until all taken. So antibiotics, we try to take it for the full course of the therapy. And the second one is stronger, or I guess that's a weaker one, but it's a second recommendation for a lower dose of doxycycline.
So you said instead of it saying 2 to 10, you said that it should be taken until it's all.
Yeah, we generally take antibiotics until they're all taken. And the reason for that is what? Prevent resistance.
For dentistry, would it still be only like short-term treatment, or would it be still long-term that
For periodontal disease, oftentimes those last longer than typical infections, so the 10 days I think is right. Okay, now vancomycin has nothing to do with tetracycline and does not share a mechanism of action with it or anything else. Totally different drug. Okay? So vancomycin is a complex glycoprotein, bactericidal. So what's tetracycline is bacteriostatic, bactericidal. So it's like penicillin, the cephalosporin. Vancomycin is used to treat sepsis or endocarditis caused by MRSA. What's MRSA? Methicillin-resistant Staph aureus. Good. And so if you're treating MRSA, you have to give it IV. Okay. It's also used to treat Clostridium difficile, antibiotic-associated colitis in the gut. In that case, you have to give it orally because it's not absorbed across the gastrointestinal wall. It's a big molecule. So if you want to have the effect on the gut, which would be most of the time, it has to be given orally. If you're going to give it for systemic effect, it has to be given IV. Now, we'll talk about metronidazole the next time, providing the school is not burned down. So vancomycin is used after metronidazole fails in the treatment of Clostridium difficile infection. And there are some contraindications to the use of metronidazole in certain patients, so it would be used maybe first choice for those patients. Oral vancomycin is the first drug of choice for second recurrence of Clostridium difficile infection. So, I read someplace at one time that metronidazole is about 50% effective for Clostridium difficile. Vancomycin is about 70% effective. And then what do you do with the rest? Might have to do fecal transplants. Okay, vancomycin is bactericidal. Inhibits cell wall synthesis by binding very tightly to ACLD alanylalanine. So similar to the action of the penicillins, but a little different site of action. Administered, and we talked about that. We'll distribute, well distributed in the CSF in inflammation, meaning the meninges are inflamed. It may not get through unless the meninges are inflamed. Mainly excreted in the urine, unchanged. does not concentrate in the bile, 50% bound to plasma proteins. So this just shows the site of action for vancomycin. It basically caps, this is the growing peptide that basically puts a cap on there so it can't grow anymore.
I'm sorry, you said it does get through with inflammation, or that's expensive?
Generally, you need inflammation for a lot of these drugs. These are big drugs to get into the brain because it kind of breaks down the blood-brain barrier a little bit. So there are a number of reasons why drugs become resistant to vancomycin. And so this is a list of how the cell has changed the structure of the target site for vancomycin. Generally, that would be called VRSA, vancomycin resistant Staph aureus, when you get there. So you might hear that term. Okay, adverse effects. Rapid IV may cause red neck or red man syndrome. Comes from release of histamine in the patient produced by the drug. Now, morphine can actually produce, looks like a line going up your arm. Looks like blood poisoning, and that's from release of histamine. So the mast cells sometimes are triggered to release their contents by molecules of various shapes. So this is a mast cell histamine release problem. All right, so it says, okay, if you're going to give it IV slowly, or you can give it by giving it antihistamine ahead of time. Remember, antihistamines work in advance, but if you try to give them after the reaction's already occurred, they don't work very well because they don't block the ongoing effect. Ototoxic. Tomorrow we'll talk about other large antibiotics that produce eighth nerve damage and renal damage. Vancomycin also shares those properties. It produces eighth nerve damage, hearing loss, and renal damage. So that'll be a similarity between drug groups when you get to it. Nephrotoxic, but less so with current preparation. Okay, then this is dosing, and I think it's self-explanatory. If you have any problem with that, let me know. And there's different recommendations for like Clostridium difficile and I guess the other was MRSA. Teicoplanin is another antibiotic that's similar to vancomycin. That's all you really need to know about. Okay, so some patients develop VRSA, vancomycin-resistant Staph aureus. What do we do? So the answer is Linezolid. So this is like our third backup for resistance to like the penicillin. So it's active against gram-positive organisms and mycobacteria tuberculosis. Is the VRSA, belongs to an oxazolidine group of antibiotics. Oxazolidines are not just antibiotics. There's other agents that are like that. Inhibits protein synthesis by binding to the 50S ribosome, 23S version of the 50S ribosome. And there's a couple other agents like that. So Linezolid taken orally, half-life about 4 to 6 hours, not effective, does not affect the P450 system. And doses 600 milligrams twice daily. Used to treat vancomycin-resistant Enterococcus fecum infections, which I guess are a problem in deep periodontal disorders. I think that has become a problem of very resistant organisms. So here's an agent that could be used in that case. Adverse reactions: nausea, vomiting, diarrhea, headache. Long-term bone marrow suppression, thrombocytopenia, constipation, dizziness, and so forth. So remember, we go from the first choice, which is the most effective, least toxic, and then as we go down the list, they get more toxic. So what you see here. Now, one of the quirky things about Linezolid is it's a monoamine oxidase inhibitor. And monoamine oxidase metabolizes many important biogenic amines. And so we're going to prolong the action of like norepinephrine and dopamine and serotonin. But if the patient's taking any exogenous monoamines like decongestants or drugs like what we call the SSRIs, selective serotonin reuptake inhibitors, or other drugs like that, they can get overdose reactions because by blocking the monoamine oxidase, we're preventing them from being clear. And so they get high doses. So we want to avoid, or we need to not give those kinds of drugs if the patient is on Linezolid. And the next page just talks all about drug interactions. So that's basically what I just told you. Then we have quinipristin, dalfopristin, used for MRSA. What are you waving at? It's another one of the antibiotics. I'm not going to go through it in great detail here. Okay, where's this?
Cuba.
That's something big.
Montego Bay.
Exam question.
Okay. There's a study question. So, what's the answer to the study question?
Montego Bay.
No, that was the last question. Okay, it's chlortetracycline. The answer? Okay, on a mission trip, a dental student was bitten by a tick and was later diagnosed with Lyme disease. The agent of choice for treating this condition would be? Tetracycline.
That's what I've been reading.
There's a lecture on tetracycline. Okay, any questions?
Why is that?
Because it killed it.